Welcome to this clinical review on aneurysmal disease, based on Tintinelli and Rosen's principles, presented by Dr. Nasser Hassan. We begin with the abdominal aortic aneurysm, or AAA, which is famously known as the great mimicker in emergency medicine. An aneurysm is a permanent, localized dilation, defined as at least a 50% increase in arterial diameter. For the abdominal aorta, a diameter of 3.0 centimeters or more is considered aneurysmal. Pathogenesis is multifactorial, but tobacco smoking is the strongest risk factor. The classic triad of AAA is hypotension, back or abdominal pain, and a pulsatile mass, though it is present in less than 50% of cases. Misdiagnosis is common. Look out for renal colic, diverticulitis, or musculoskeletal pain. Note that the sensitivity of finding a pulsatile mass decreases with increasing BMI. Rupture risk increases exponentially for AAAs over 5.0 centimeters, or 5.5 centimeters as shown here. Key risk factors include rapid expansion rate, active smoking, hypertension, and female gender, as rupture can occur at smaller sizes in women. POCUS, or bedside ultrasound, is the gold standard in the emergency department, with a nearly 99% sensitivity for identifying an aneurysm. Remember to measure outer wall to outer wall, scan the entire infrarenal aorta, and carefully measure the true lumen while accounting for mural thrombus. Emergency management involves permissive hypotension, targeting an SBP of 80 to 90 millimeters of mercury to prevent popping the clot. Early vascular consultation is mandatory, as a ruptured AAA is a surgical emergency. Activate the massive transfusion protocol early, aiming for a 1:1 ratio of blood products. Next, we will look at thoracic aortic aneurysm, TAA, focusing on its evaluation and life-threatening complications. TAAs are often asymptomatic until rupture or dissection. Symptoms, when present, can include hoarseness or dysphagia from compression. Rupture presents with catastrophic chest or back pain and shock. CT angiography is the diagnostic gold standard for TAA. This table summarizes the management differences between TAA and AAA. Note the different primary imaging, rupture symptoms, and intervention size thresholds, especially for ascending TAA. A key pearl is to always consider a ruptured AAA first in any elderly patient with sudden back or abdominal pain and syncope. Be careful not to mistake AAA for a first episode of renal colic. While CT is highly sensitive, it may not differentiate a leak from a contained rupture. Finally, keep the patient NPO, prepare cross-matched blood, and provide analgesia to manage the sympathetic response. Thank you for your attention to this life-threatening emergency. If you have questions, you may contact Dr. Nasser Hassan at the provided email address. These are the image sources used throughout this video.